Good morning, all, and thank you very much for coming. I want to try to tell you a story that began about some 20-odd years ago, and it's a part of our work where we use a particular neuroleptic that eventually is used to treat incurable infections of tuberculosis. These are the main individuals of various groups that we work with, and nothing that is worthwhile to be done can be done alone. And all of these individuals here have made huge contributions to the story that I will be telling you about today. The whole world knows about tuberculosis and the dangers of tuberculosis and the problems that multi-drug resistance has, during the last 30 years or so, has posed for the health industry. The normal way to treat tuberculosis infection involves isoniazid and rifampicin, but because of the rapid rate of resistance, which is referred to as multi-drug resistant tuberculosis, these drugs have become relatively ineffective. But there has been progression to other increased levels of resistance, such as the extensively drug-resistant population. And now we have gone even further to totally drug-resistant MTB, which remains to be defined. Apparently, some of these strains that have been isolated in Iran and also in India are resistant to everything, and the patients will die very quickly. The WHO, which is the political organization, has organized a variety of programs, and these are the programs that they insist ought to be used. And for us, it is the development of drugs that can be used effectively anywhere in the world, with price kept in mind. Most of the TB that occurs in the world and multi-drug resistance occurs in countries that are very, very poor. And in fact, because these drugs, conventional drugs, cost so much money, they're used infrequently, and this causes an increase in multi-drug resistance. But we're trying to avoid all of this by developing drugs that anyone can afford, simply because they're very cheap. So we develop a variety of compounds, and we'll tell you a little bit about them, but primarily we'll be working with thioridazine, which is an old neuroleptic, used still in the United States, banned in the UK, with the sole exception that it can be used for the therapy of psychosis. The studies that I will refer to you involve a variety of phases, where we go from in vitro to ex vivo to the animal, eventually to the therapy of the human. We'll first talk about multi-drug resistant tuberculosis, which includes MDR-TB, XDR-TB, and TDR-TB. We define these as organisms that are located primarily in the macrophage of the human lung. They stay there for a number of years, and usually as a consequence of age, during the 5th and 6th decade, they resurface and cause infection, that is, active disease. Most people think that an infection of TB is the same thing as what is normally reported by the WHO. And this is not true. Infection of the patient with MTB rarely results in active disease. And usually only about maybe 2 to 5% of the patients that are infected with MTB will express during the 5th and 6th decade of life an actual infection. That is the infectious part of the disease. So the difference between infection and active disease is extremely important. Infection does not result in transmission of the organism. Active disease does. And this is the time when the organism breaks out of its macrophage prison, and now it is found in the sputum. And when the patient now begins to cough, yell, scream, or dance, and sing, the organism is now available for transmission to individuals around. So active TB is infectious. The definition of various levels of resistance, as I mentioned before, MDR-TB is resistant to INH and rifampicin. XDR-TB is resistant to a variety of antibiotics, making therapy rather complex and difficult. And now, in India, in one single hospital in Bombay, 5 cases of TDR have been found. In a population of 15 million people, to find these large number of cases in a single hospital means that TDR-TB is here. And probably, as we found in New York some 20 years ago, there were examples of this type of infection. And the problem with this is that when you have a case of TDR-TB, you're going to lose a patient rather quickly. This is the distribution of tuberculosis infections worldwide. It's meaningless, simply because most of this data over here is false. And the reason I say it's false is because they rely on reports from various countries. Some countries are very nationalistic. They don't want to talk about an infection rate, which they feel is rather embarrassing. So the reports that are given to the WHO are not always accurate. But this is a sort of a worldwide distribution of just cases of new cases of TB. All of these cases are active disease. They're not infections. The worldwide infections rate is about somewhere like around 3 to 4 billion people. These are just new cases which reflect the active disease process. What is meant by new cases of TB? Meaning active TB. They're not infections. These are active TB cases. The number of infections is estimated to be somewhere like around 4 billion people out of 7 billion that exist today. Here's an example of the WHO report, and with respect to XDR-TB and TDR-TB, no one knows what their frequency is, but I'm sure that it's quite high. Most places in the world do not have the laboratory facilities to be able to identify fully the XDR-TB and the TDR-TB situation. Mortality. Mortality with MDR-TB depends upon where the patient happens to be, but it's not uncommon to have anywhere as 80%, especially when you have co-infection with HIV and the patient is presenting with AIDS. When you have a situation involving XDR-TB, 80% will die within 6 months, regardless of what you try to do with respect to the patient. What is the probability of mortality with TDR-TB? No one knows. The problem that we have today is that we have no drugs that are active or effective against MDR, XDR, and TDR-TB, except for, and I'll give you an example of what we have done with this particular unknown, and the essential characteristics of what a drug must do if it's going to be an effective anti-TB agent. It must have activity against all forms, regardless of the antibiotic susceptibility status. They must have activity where the organism resides, that is within the macrophage. And they must have no toxicity, and no resistance should be made against the drug as a consequence of mutation by the organism. This is a heck of a lot to ask of a drug. Very difficult. Hundreds and hundreds of compounds are identified each and every year for in vitro activity against all forms of TB. However, very few, if any, actually get to the point where they have activity where the organism resides, and that would be in the macrophage itself. The history of phenothiazines with respect to infections, as early as 1890, methylene blue was shown to have a variety of antimicrobial activities, and as recently as 1996, it was demonstrated that the main compound, chlorpromazine, that was developed back in the 1950s, had activity against all forms of MTB. This is a kind of timeline as to the progression of a phenothiazine such as methylene blue with eventual compounds that have very good activity against a variety of mycobacteria, including Mycobacterium avium, by the way. Serious side effects are produced by chlorpromazine. It's a nasty drug, produces terrible things. And luckily, from chlorpromazine, thyrazine was produced in the early 1960s, and it has been used for over, I guess, 45 years or so, relatively safe. However, in England, a bunch of idiots thought that it could be used for the therapy of dementia as opposed to psychosis, and a large number of patients died, and therefore in England, thyrazine is now restricted to only one use, and that is the therapy of psychosis. And even then, people like to stay away from it because of the history that took place a few years back. We'll be talking about thyroidazine and some of the derivatives of thyroidazines as relatively good drugs for the therapy of MDR, XDR, and TDR-TB. Mellaril is the trade name for thyroidazine. And as I mentioned over here, the most common side effect is drowsiness. So if you give very large concentrations of thyroidazine to a patient, they get sleepy until they eventually develop resistance towards it, and then they can function relatively normally. But during the first couple of months, they will feel sleepy, somnolent most of the time. These are two phenothiazines which are very common. Chlorpromazine is the second most studied drug, over 44,000 papers on chlorpromazine alone. The only drug that has been used and reported more often is aspirin. So this drug over here, chlorpromazine, a good deal of the chemistry is known. Thyroidazine, less so. So there are not too many people that work with thyroidazine, so therefore most of the work that I will show you will be our work. These are examples of TB from its diagnosis. The compound itself, here we have the macrophage with the MTB in the cytoplasmic organelles, the mouse that we will treat, and the mechanism of action in terms of how the organism is killed by the macrophage. This is an example of what to expect when you do an in vitro assay involving chlorpromazine and thyroidazine. And these are the various strains that are resistant to as many as 5 individual antibiotics. This is really an XDR-TB case. And here we had over 10 patients in one single hospital in New York City back in the early 1990s that were already presenting with what is referred to as XDR-TB. So we're talking about something that's been around for at least 20 some odd years, perhaps if not longer. But the main point here is that wherever you're using chlorpromazine, the MICs, that is the minimum inhibitory concentration, the two drugs are about the same. So thyroidazine is equal to chlorpromazine as an anti-TB drug in vitro. Now, this doesn't mean too much because these concentrations are impossible to be reached in a patient. The most that we can have in a patient is about 0.5 micrograms per ml. So therefore, all this data that I showed you there is irrelevant, clinically irrelevant. And this is the case for most compounds that are reported in the literature. The concentrations that are active in vitro, that is in a test tube, cannot be reached in the patient. So the maximum that we would expect when you treat a patient with, let us say, chlorpromazine would be somewhere in the order of 0.5 milligrams per liter of plasma. Whereas before, as I showed you before, the concentrations are hundreds of times greater than would be possible inside the patient. We're going to be talking about some experimental studies, and it's important for you to have some understanding of what it is that we're doing. So we screen for derivatives of thyroidazine that are synthesized. We looked at over 100 of them. And then in vitro, we do some mutagenic assays to make sure that we're not going to be developing compounds that will produce mutations in the human. Toxicity is very important, so we look for compounds that have low toxicity, if any, no mutagenicity, and we test the compounds first against Staph aureus. Why? Because Staph aureus shares about maybe 80% of its genes with mycobacteria. It takes approximately 45 days to get a complete analysis with mycobacteria, and we can get the information that we wish with Staph aureus overnight. And therefore, it provides us the guidelines and the guide to be able to select drugs for future screening. So we use Staph aureus as a model, and if it works rather nicely, then we go on to tuberculosis, okay? The infection studies will go from in vitro to ex vivo studies. Eventually, we do toxicity, and we treat mice that are infected with both antibiotic-susceptible MTB as well as multi-drug resistant tuberculosis strains. The system that we used originally is one called the Bacter 460, which involves the identification of the release of CO2 from radioactively labeled palmitic acid. So when we put the palmitic acid into the solution, the mycobacteria utilize it, they hydrolyze it, and you get CO2 that is radioactive, and the instrument picks up that radioactivity through a gas flow system. These are examples of some of the derivatives that we work with. And so that we start off with thyroidazine. Georgi Hadges from Budapest, he's director of the Institute for Chemistry of the Hungarian Academy of Science, was able to synthesize a few hundred of them. We tested about maybe 90 of them, and these were the most active ones, which are I think there are 22 of them. And when we test them in vitro, these are the examples of the MICs. And the ones in red are the very active ones in comparison to thyroidazine, which has an MIC at the 50% range of around 10. In other words, 20 is the MIC. This is the 50 percentile level for this particular activity. And you can see that some of these here are pretty good with respect to their activity. Primarily the 1875 and the 1870. And remember, this is in vitro. And these concentrations are very, very high. And they cannot be achieved in the human. However, when we work with a macrophage, that is, we have the macrophage is isolated, we then load it up with mycobacteria, and then we treat and add to the system these derivatives, and then examine the number of CFUs, that is the number of microorganisms that are found, or MTB that is found per day. We find that E, G, and H are the ones that have the greatest activity. And these over here are less active. So these are the compounds that we would focus on for further study. Intracellular activity of non-phenothiazines? Yes, we have a particular compound called 421, a silyl compound. It is a silicon-based compound that is the most active one that we've ever seen with respect to activity in vitro and macrophage activity, as you will see here. This is 421. It is derived from the 409 compound, and we can see that very rapidly we have practically no growth at all, whereas our control is here, and here is the activity of the drug 409. So therefore, this is a very powerful drug. This drug was developed as an anti-cancer agent some years ago. It has no toxicity and works very actively against the MTB that is within the macrophage itself. In vivo studies. This involves the use of a mouse, females, because females are more easily infected with MDR-TB. You have to remember that mice normally do not get infected with MTB. But we have to use very high levels of the infectious agent. And we introduce this through an IP system such that the controls have no TZ. After infection, we add the TZ, the thyroidazine, in terms of kilograms per day, which is about maybe 10 to 20 times higher than is normally used in the human, only because the mouse can tolerate 10 to 20 times higher levels of drug than the human, because its heart beats about 10 times faster, and therefore the clearance rate of whatever you give the mouse is rapidly done by the liver and the kidneys. So we do this, and then on a periodic basis of every 10, 15, 30 days, we sacrifice animals, we remove the organs, homogenize them, and then we extract the bug that is there and do a numerical count. So this is the data that we get. In case of the organism, this is the control, continuous infection. Within 30 days after the application of thyroidazine, we get a major drop. However, we do not get complete elimination of the organism, primarily because the other two organs, which contain a large number of macrophages as well, retain the organism. They become seeding parts, so that the organism is now transferred from the liver and from the spleen throughout the systemic system, and we keep on reinfecting the lung. So this is a major problem with respect to these two organs here. The work has also been confirmed by other investigators. I worked as a consultant for them, so therefore it's not totally cannot be totally considered to be an objective situation. And what they were able to demonstrate is that if you use, in this particular case, thyroidazine alone and in combination with either rifampicin or INH, you find that in all cases you have a very rapid reduction in the number of organisms that are retrieved from the lungs. And when you look at the tissues, you will find that in each particular case, there is more of a resolution of the infection as opposed to the control. So at the tissue level, it seems to be effective. They were able to confirm the fact that even when you work with MDR-TB as the infectious agent, you get cures. Rather, within a few days, actually 70 days, I believe, as opposed to, took us about 360 days to produce similar cures when we worked the other way around. Now, what does it mean clinically? Well, we have group in Argentina. And there we began in 2003 to apply what we already knew in vitro and in the macrophage to treat patients that were infected with XDR-TB strains. And we began this in 2003 with 5 patients. We had some positive results. And then Eduardo Abati has a very large group in Argentina, and they were able to look at the effects of thyroidazine in combination with antibiotics to which the organism was resistant. And these are the results. Unfortunately, this is in Spanish. Curación means cure. This particular patient was abandoned the protocol because they felt pretty good, and therefore they were no longer participating in the project. But here we have, these are all cures. And some of them were established within just a matter of days. Here, 90 days, 28 days, 14 days, just using thyroidazine in combination with 3 antibiotics, to which the organism was resistant. They did another study which was published just in the January issue of Journal of Antimicrobial Chemotherapy with additional patients, another 12 patients, and again they established remarkable cures. So those of you who are interested may want to look at that particular issue of JAK. Mechanism of action. Well, it's very important to understand how these things take place. When we look at the macrophage, we already know that with respect to a neutrophil, for instance, the killing activity against any organism is based upon an inhibition of potassium efflux from the phagolysosome that contains the bacterium. In the macrophage of the lung, there's no killing activity. Therefore, we assumed that the reason for that was because the ability to acidify the phagolysosome is absent in the lung. And we already know that calcium and potassium efflux pumps are essential for the acidification of the phagolysosome. So what do? We began, these are the work of Siegel that demonstrated the relationship of calcium and potassium efflux pumps in case of their killing activity. So what do? We looked at inhibitors of potassium. Here, calcium inhibitor is a calcium blocker. Racipine inhibits potassium and calcium, and warbane inhibits the transport of potassium. It's an old drug that was used many, many years ago to control arrhythmias produced by flux of potassium. And we employed these separately with a macrophage that was infected with MTB. And what did we find? We found, as we had expected, that this is the MRSA model that I told you about, the Staphylococcus aureus. Here was a predictable response. We then go on to M. tuberculosis, and we find here's the control. And here we find verapamil, the channel blocker for calcium, very effective in terms of producing complete elimination, death of the organism. So, what can we conclude from this? Well, the thyroidazine is not the effective agent against the bug, but is actually activating the macrophage for killing activity. And this is very important because we now bypass any mutational response by the organism, and we simply just concentrate on activating the macrophage and activating the killing machinery of the organism, and therefore we have a different form, a different means of therapy. Therapy normally involves designing the drug that works against the organism. Here we're talking about designing drugs that are going to activate the macrophage. And therefore we bypass any mutational response of MTB. And moreover, if we use combination of the thyroidazine, like Abati did, with antibiotics to which the organism have been resistant, we add a second level of activity. And we'll be talking about that shortly. That is the effect of some of these agents on the efflux pump system of the bug itself. So, going back to what we think is taking place, we look at the binding of the bug to the surface of the cell. Now, this is the key to what takes place. You have to remember that the plasma membrane is going to be pumping in potassium. Concentration of potassium out here, and the increase of potassium here means that you have to have energy to bring the potassium inside the cell. So this is done by influx systems, transport systems. But when you now have a system by which the membrane invaginates, and now you have the bug inside that vacuole, you now have the pumping of potassium out. Okay? So here we have potassium being pumped in, but now when you have the phagosome, potassium is being pumped out from inside this vacuole to the cytoplasm. When we now go to the next step, we now have the same situation. We have here the bug, and we have the calcium and potassium is being pumped out, etc. And now when we put in the thioridazine, as you will see in a moment, here's the thioridazine. That too is brought in under controlled conditions. So it's brought in as a vacuole, and eventually that will fuse with a phagolysosome. Okay. And eventually, as we have over here, fusion takes place. And now we have the situation in which the efflux pumps will be inhibited. And we have the potassium remains inside. We have the activation of the hydrolases and the killing of the organism. Very simple, and it's testable. And so far, everything that we've done tends to suggest that this is one of the mechanisms of action involving the phenothiazine in terms of activating the macrophage itself. The role of efflux pumps in terms of the MDR-MTB or XDR-TB, etc. Laboratory demonstrations of how we can bring about resistance to, let us say, INH or any other compound by slowly training the organism to become more and more resistant to the antibiotic. We can do this with INH. This represents increases in the amount of INH that we put in and the increase of the MIC. So this is where we begin, where it's very susceptible. And we can see that the MIC increases. And at the end of around 200 days, we have an increase from 0.04 to 40 micrograms of the INH. And if we put in something like thioridazine, we find that immediately the efflux pump system, as demonstrated by here, reduces the MIC from this level to just about that which was initial. That is 0.4 micrograms of INH per ml. If we transfer the bug to drug-free medium, we get a more slower effect, such that to get complete reversal of resistance to its original form requires almost a full year. So by the way, you can also use reserpine to do this, or any other substance that inhibits potassium or efflux pump activity. How do we measure efflux pump activity? Very simple. We work with an automated system. It's a PCR system that utilizes ethidium bromide. Ethidium bromide is activated at a wavelength of around 535, and it emits a wavelength of fluorescence at 585. So we have an instrument that is pumping in the activation wavelength, and then we get the activity of the ethidium bromide. So as we have more and more ethidium bromide accumulate within the cytoplasm or the periplasm of the cell, we get more and more fluorescence. So the more fluorescence we get, the higher the retention of the ethidium bromide, and therefore anything that interferes with the retention, that is, it makes the organism accumulate more and more, would be an indication of an inhibition of efflux pump system. Now what we do to make things very simple, whoops, what happened here? What we do is we load the organism with ethidium bromide, we wash all the ethidium bromide out, and now we see what happens with ethidium bromide with time. So here we have the control, and in the control where we have some energy but none of the inhibitors, we find that we have efflux. When we put any one of these inhibitors, there is no efflux. So this is a demonstration of these materials here having an activity against the efflux pump system of the organism itself. When we now begin to do some studies, in Mycobacterium tuberculosis, we've been able to identify at least 5 efflux pump systems. All bacteria have redundant systems. E. coli has over 28 efflux pumps. Knock out 1, 2, 3, 4, 5, up to 9. And the other remaining efflux pumps take over. They're less effective, but they allow the organism to survive. The same thing with Mycobacterium tuberculosis. These are the main efflux pumps of the organism. Here we have the control, the expression of the genes for each of these efflux pumps, and these are clinical strains that we have been able to obtain. And for each one of these clinical strains indicate that those genes are much more active than the control one, indicating that these strains, which are resistant to YNH, and as well as other antibiotics, is due to the efflux pump activity, and which we can eliminate all of this efflux simply by just putting in some pyridazine or some verapamil, because all of these efflux pumps are ABC transporters. And verapamil, which is a channel blocker, will effectively block the transport or the efflux, and therefore these will now assume, well, more or less, the phenotypic genetic activity of the control. So what conclusions can be made about all of this? Well, pyridazine has activity in vitro, has activity in the macrophage where the bug is found. Pyridazine cures the mouse of a MDR TB infection, and pyridazine cures the human of an XDR TB infection. It's a dual mechanism of action, that is, it inhibits the efflux pump of the organism as well as the efflux pumps of the macrophage, activating the macrophage, contributing to the destruction of the mycobacteria, and by all means it bypasses any mutational response made by the MTB that will lead to resistance. So the concept is entirely different from that which is used to develop drugs that act directly on the organism. Pyridazine is cheap. For about 250 euros, I get a kilo. I can treat an entire village of people that are infected with MTB for 1 full year. It costs over $500,000 in the United States to treat one single case unsuccessfully of an MDR TB infection. And here we're talking about pennies. But the patient ought to be monitored first for cardiac function and periodically. Why? Because there are cases where pyridazine will cause a prolongation of the QT wave. That is, the time between the contraction of the left and right ventricle is increased. And it occurs in infrequent cases, but if you slow down the heart enough, you put the patient at risk for sudden death. So patients ought to be examined first for the possibility that they already have underlying cardiac problems. And then once you do this, you monitor the patient frequently. And this will prevent any possibility of the patient responding in a negative fashion to the therapy itself. We published a special issue just last year, and as a consequence, others have begun to work with a variety of methods examining the effect of pyridazine. For instance, Duta, that was Dastidar's patient, Dastidar's student, has been able to demonstrate that all of the essential genes of Mycobacterium tuberculosis are inhibited by pyridazine. And that's important. The Dario Udvadia, has treated a large number of patients in Mumbai just with pyridazine alone. The quality of life is rapidly improved. He has not been able to cure anyone because he uses very low levels of pyridazine, limited to about 75 milligrams per day. But with respect to how those patients felt, they began to lose all the symptoms of an infection. Their appetite was regained. They put on weight. The anxiety associated with the disease disappeared. So the quality of life was extremely important, and he recommends that the drug be used for salvage purposes. And then another individual by the name of Chuck Sohaski was able to demonstrate that pyridazine is the only compound known to inhibit and kill dormant tuberculosis. Now, this means that in all probability, the same situation would apply to latent tuberculosis, which represents the infection itself. And so far, pyridazine seems to be the only compound that seems to have an effect and kills the organism, whereas the others do not. This is the group that I have in Portugal. These are very hard-working people. This is my closest assistant is Miguel Viveros, Isabel Couto, and these are the students. And these are our foreign students from Hungary, and this is from Greece. And we have additional others that have come in late. But as I mentioned to you before, we have a large number of groups that work with us all over the world, and I was able to show you that before. So nothing that is worthwhile can be done alone, and no one knows where one's thinking begins and the other one ends, and vice versa. So we are indebted to so many people who brought this whole story almost to conclusion. And I'm no longer going to be working with MTV simply because others can do a much better job with respect to therapy. I thank you for your attention, and I think I've used just about 2 more minutes than I should have. Thank you.
something we have been thinking of very much when we have been working in clinical science. Did we develop them wrong when we used them as psychotropic? And we should not have them developed from the first beginning to be people's usage. You are showing us here that they are so different. From what we know, they have quite new possibilities we have never really realized before we were coming up with these very complex systems.
And that is the fault of Paul Ehrlich, because he was the one that claimed that one drug for one pathology. And unfortunately, this works rather nicely for the pharmaceutical industry, because in the United States we have the FDA, and the FDA believes in one drug approved for one single purpose. So to use that drug for any other purpose requires an act of God. Very difficult to do so. So it's rather interesting. For instance, INH was used originally for other purposes, and somehow it became an anti-TB drug. But today, it is very difficult, if not impossible, to have one drug that is used routinely for one particular purpose to use it for another. And this works rather favorably for the pharmaceutical industry, but works against the patient's needs. So right now we are in transition. Hopefully the world's regulatory agencies will help us with this, and maybe things will change. I doubt it very much, but hope we can still hope.
In Argentina, we had some very difficult patients, and they were treated, and they were, you mentioned that they were followed at least as far as I can see up to what?
The study, you know, they've been followed for 5 years now.
Yes, and for how long were they actually treated with the TB drug and
Well, they were treated. We showed you where the radiological picture indicated a cure.
Yeah, but cure, is that microscopic or pulsar?
Both. With the cure means that there was no acid fast positive microbes in the sputum, and number 2, the cultures were negative, and number 3, there was evidence of a cure at the level of the lungs through radiology.
Yeah, but you only, I mean, very
9 months is about the maximum period. It's very short with comparison to the chronic therapy of a psychotic patient with, let us say, any one of these phenothiazines.
Yeah.
So it's a short period, and therefore it's profitable because you can use very high levels of thioridazine, you know, somewhere 200, anywhere between 200 and 1,000, and you're relatively sure that there will be no lasting effect, as opposed to lifelong therapy as you would have with thioridazine for the psychotic patient, which could be 1,000 grams every day for the remainder of their lives. Yes?
Thank you for your comment about big pharma, which I appreciate. My question is sort of related to that, and that is that it seems as though you established that fluorescein inhibits the efflux.
Yes.
My question is, what is known about the mechanism of action? Is that a drug?
Well, I can.
Protein interaction, or is it mediated by the environment, which is sort of may explain why you have a series of effects?
Okay. It does not have a direct effect on the efflux pump itself. It has an effect at levels of energy before the activation of the pump itself. In other words, what happens is that at a pH, let us say, of around 7.4, the efflux pump system that relies on the proton motor force is not very effective. So when we have a drug that now acts on the PMF by denying, let us say, the mobility of hydronium ions through the cell envelope, and eventually causing the acidification on the other side of the membrane, which is required for the activation of the pump, it inhibits that process. It also inhibits the utilization of metabolic energy sources such as glucose, etc., because the enzymes that are involved in the metabolic processes are all inhibited. All the phenothiazines, depending upon the concentration that you use, have the ability to inhibit all energy-dependent systems. The concentration has to be increased, simply because the higher the concentration, the farther the target is, the better chance you have of hitting it. These are non-specific activities. But the effect on efflux pumps is indirect. There is no evidence whatsoever that it occupies a niche and therefore prevents the recognition of the substrate that is to be effluxed out. It's usually it involves the inhibition of energy sources. In fact, all the inhibitors that have been looked at in terms of microbiology, all of them simply compete with the substrate, ethylene bromide, And therefore, you're looking at different degrees of binding affected by the type of substrate that you have. So aethylene bromide has a particular constant for binding for recognition, and various compounds have different degrees of activity and competition, so that when we work with some of these compounds, they are preferentially bound as opposed to aethylene bromide, and therefore it appears that aethylene bromide accumulates. I don't know if I make myself understood, but it's an indirect effect, mostly competition as opposed to an actual inhibition of the pump itself. And all these things that people claim are inhibitors, they're not. They're competitors.
So that actually means that there are lots of room for optimization.
Yeah, of course there is. Yes. Yeah.
It's not a matter of fitting the logic.
It's like an enzyme. You know, the enzymes. There is a collection of enzymes that recognize substrates. In this particular case, a large variety of them, and simply just the things that compete to different degrees are effective, and therefore the drug is retained in situ, not pumped out, and the substrate is primarily pumped out. So therefore, you have all of these possibilities. Nothing more than a collection of enzymes, and they behave like enzymes. And all of those efflux pump studies, by the way, are done at 37 degrees under relatively good, mild physiological conditions, at pH 7.4. The ionic strength of the medium is, we're using saline as an example, and we put in an energy source. You can put in glucose, you can put in ethanol, which is less effective, or any intermediate in the glycolytic cycle. But they're all effective in terms of providing the energy required at a pH of 7.4 for the conversion of a variety of substrate at the level of metabolism. I'm sorry, I can't. Yes. Yes. Well, the situation, it depends in which country. In the United States, individuals that are infected with HIV and progress to AIDS, they are very susceptible to Mycobacterium avium, which is everywhere. In places like Lisbon, for instance, less than 5% of the mycobacteria that you retrieve from the tuberculosis patient are of avium type. And the reason for that is because all the people in Lisbon are already infected with MTB. So when they go from HIV to AIDS, it is the MTB that is now surfaces as the infection, as opposed to New York, where the individuals are picking up the avium as an infection, and because their CD4 plus cells and CD8 cells are very low, that infection takes over. So in New York, the co-infected HIV patient presents with Mycobacterium avium as the primary organism. In Lisbon, it is primarily MTB. Yes.
Just a little question. When you presented the necessity of heart monitoring when dealing with bioediting, could you give a comment on the dimension of this problem when dealing with so serious diseased patients as those ones suffering from XDR disease?
Well, it's very easy to treat a patient that is infected with MTB and is presenting with active forms. That's very easy. In fact, there was a reason why everyone thought in the 1950s that the incidence of TB infections would be eradicated. That is not the case, because when you treat a patient with TB, you're treating a patient for 9 months to maybe as long as 2 years, and the mutation rate, which can be as much as 1 per every million or 100,000 replications or less, they accumulate, and therefore, when you treat a patient, say with INH or rifampicin, and a spontaneous mutation takes place, you select for that bug. So you wind up with single resistance, mono resistance, and then you wind up also with multi-drug resistance. Those patients are much more difficult to handle, depending upon where you're at. Not so much because of the resistance of the organism, but because the competence that is necessary to treat such a patient, and the support that is necessary. You need diagnostic laboratory to be able to identify the patient very quickly. We do this within the same day, so we can identify the MDR-TB patient that same day, and then isolate him, treat the others conventionally. Before that, all patients were treated aggressively, and this contributed to a higher incidence of MDR-TB. So we've been able to reduce in Lisbon from approximately 28% down to less than 4%. However, half of that 4% is XDR-TB. So we now have most of the patients presenting with XDR-TB as opposed to MDR-TB as a consequence of, well, there are problems in therapy. That's about all I can say about that.
Thank you very much, Len.